Hi, I'm Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology at Emory University Spinship Cancer Institute. Well, first, if we take a step back and look at stage 3 unresectable patient population, this is a group of patients where the standard of care for a very long time was concomitant chemoradiation alone. We know that with concomitant chemoradiotherapy, the 5-year survival rates are approximately 20%. The median survival was approximately 20 to 25 months in recent randomized clinical trials. Several efforts to improve the effectiveness of therapies or improve the outcomes for stage 3 unresectable disease were not successful. The great news is now we have a new approach to improve overall outcomes for this group of patients. The use of adjuvant durvalumab in the PrecisCa trial showed significant improvement in overall survival and disease-free survival for this group of patients, or progression-free survival for this group of patients. To refresh your memory, the PrecisCa trial enrolled patients with locally advanced disease after they had received chemoradiotherapy, and if they had benefited from chemoradiation, in other words, if they did not experience disease progression, they were randomized to 1 year of durvalumab or not. And in this trial, we saw improvement in overall survival with a hazard ratio of 0.67, favoring the use of durvalumab. We also saw more recently that the 4-year survival rate for this group of patients was highly impressive at nearly 48%. So clearly the standard of care for locally advanced surgically unresectable disease has changed. We also know from the PrecisCa trial that benefit was seen across both histologies, squamous and non-squamous. While PD-L1 expression was not a predictive biomarker for entry into the study, an exploratory analysis was done. It showed that the PFS was improved for both PD-L1 low and PD-L1 negative and high patients. The overall survival results were seen primarily in the PD-L1 positive group of patients. However, we use this regardless of PD-L1 expression at this point of time. Now, when do we start durvalumab after patients have completed chemoradiotherapy? Typically, it takes about 2 to 4 weeks to let these patients recover from any toxicities that they may have experienced. And we do a scan around 4 weeks after chemoradiation has been completed. If we do a scan too early, we may end up picking up a lot of inflammation and not be able to distinguish between what is a good response versus what is an inflammatory response to chemoradiation. So in my practice, I wait for about 4 weeks before the scan after chemoradiation is done. Now, what is the best time to start durvalumab? In the PrecisCa trial, patients were allowed to start durva as early as 2 weeks after chemoradiation therapy. In fact, there was a favorable trend for patients who started durva earlier on, right after chemotherapy, within around 2 weeks of time. Now, there is some selection bias in this because if a patient experienced substantial toxicities, then those patients are more likely to have started durva later versus a patient who did really well with chemoradiation starts durva early. So the answer to that question is as early as it is safe to start durva after chemoradiation is the best time. So it varies from patient to patient. We obviously want to start it no later than 6 to 8 weeks. My approach would be if a patient does really well during chemoradiation within 2 to 3 weeks of completing chemoradiation, I would set that patient up to start durvalumab. If a patient struggled and has a lot of ongoing performance status or esophagitis issues, I would give a little more time for that patient to recover and then start durvalumab. The goal is to make sure that every patient who undergoes chemoradiation who has a good clinical result be able to start durvalumab in a reasonable time and then hopefully be able to complete 1 year of therapy.